Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graban.
Hi, this is Mark Graban. Welcome to episode 240 of the podcast. It's January 26, 2016. My guest today is someone I've wanted to interview for a long time. She is Leah Binder. She's the president and CEO of Leapfrog Group. And Leapfrog Group is a nonprofit based in Washington, D.C. They're described as, quote, a voluntary program aimed at mobilizing employer purchasing power to alert America's health industry that big leaps in healthcare safety, quality, and customer value will be recognized and rewarded. So in our discussion today, Leah will talk about the story behind Leapfrog Group, the scale of patient safety problems in America, some of their efforts to grade hospitals on their safety performance, grades made available to the public, and some of the connections between lean and patient safety. So I would encourage you to check out their website and the hospital safety score website. If you go to leanblog.org/240, you can find links to these websites, or you can find it really easily online. You find out, how does your hospital measure up if you work at one? How do the hospitals in your community compare, and what are the gaps that need to be closed to improve safety in some very specific ways? And I'm also curious when we talk about this, how can large businesses who pay for healthcare and have their employees' interest in mind, manufacturers, for example, in a community, how can they put positive pressure on healthcare to improve? How can they help healthcare organizations improve? So again, for the post, go to leanblog.org/240. Thanks for listening. Well, Leah, it's great to talk to you today. I want to thank you for being a guest on the podcast.
Well, thanks for having me, Mark. I'm excited.
So can you start off, for listeners who might not be aware of you and Leapfrog Group, and I hope they are already, but can you introduce yourself and your background and how you got interested in patient safety?
Sure. The Leapfrog Group is a national nonprofit organization. We were founded 15 years ago by a group of business leaders from mostly very large companies like Marriott, GE, GM, who came together because they were concerned about safety, patient safety in hospitals, and they were concerned about health costs, and they wanted to see what they could do about it as purchasers of health benefits. In many cases, purchasers spend more on health benefits than they earn in profits in a given year. So it's a very large concern for them, and they wanted to see what they could do better to make sure their employees and their families were getting the kind of care they want and deserve, and they were getting value for their enormous investment in healthcare. So they formed Leapfrog as a way of really trying to use the market to do that. I mean, these are business leaders not from healthcare, but they were in the world of business, and they wanted to use the models of the free market to see if they could improve healthcare. And by that, they meant that they would like to see more transparency about how hospitals are doing, and allow their employees and them as purchasers to compare among hospitals on their relative quality and safety. And they wanted, therefore, people to choose hospitals based on how safe they are, and in doing so, then drive a market for the highest quality care and encourage hospitals to improve in order to attract that market. So it was a simple premise. It remains a simple premise of how we need to reform healthcare, which is to allow people to make decisions based on real information about how hospitals and how healthcare in general is doing. It's still a simple message. At the time, it was kind of revolutionary. People told those business leaders in the beginning, that's impossible. There's no way you'll have enough information, or it won't be credible. If you do get information, there's no way you're ever going to find out how these hospitals are doing. They don't want to tell you. They're not going to tell you. It's not going to work, blah, blah, blah. They were just told all the reasons it wasn't going to work. They did it anyway. And what enables them to get information, and still enables Leapfrog to get information today from hospitals that's otherwise unavailable about their safety and quality, is that business leaders in the communities served by individual hospitals ask those hospitals to report to Leapfrog. So now we have hundreds of purchasers across the country, mostly employers, sometimes unions, all nooks and crannies of this country, asking their local hospital to please report to Leapfrog. And so we get information that is available nowhere else and can be used either by consumers themselves to choose a safer hospital or by purchasers and health plans and others who are interested in value-based purchasing and other ways of really driving a better market for the best kind of healthcare. Mm-hmm. So that's what we do.
Yeah, and it's such an important mission, and the business leaders and back at the founding of Leapfrog Group and leaders today, they have such a strong interest not just in healthcare costs, but their employees' health and the safety of healthcare. But it seems like even today, at least public perception is that everyone's aware of the cost problem or the lack of affordability, but it seems like far fewer people today even are talking about patient safety and quality. Why do you think that might be? I mean, trying to get more information and data out there will help, but it seems like it's just not on the front burner for a lot of folks.
Well, I think it's a complicated problem that people have difficulty getting their arms around. It's a little bit less complicated to talk about the insanity of pricing in healthcare. And by that, I mean, the New York Times ran a fantastic series of articles last year, Elizabeth Rosenthal, talking about how the same procedure can cost, $40,000 in one hospital and then cost $5,000 or something in another hospital right down the street. And you can look at those kinds of strange disparities and weirdness in the pricing in healthcare, and there's a story right there. I mean, It's obvious there's a problem and issues that something's going on. Whereas with quality, it's very easy to get confused and say, well, this one has good outcomes, but that one has a high rate of complications, and you have to decide for yourself which is more important to you. Those things get complicated. But the fact that they're complicated doesn't mean they're any less important. Mm-hmm. And in fact, the variation in quality and outcomes and safety in hospitals is extraordinarily persistent and problematic. And there's no family in this country that shouldn't be absolutely focused on making sure they're going to the best possible places. Right. Because the difference between the best and the worst is very substantial, and your life is at stake. So it is very important for us to get our arms around it. But it's because it's complicated. I think it's easier, frankly, for some who would prefer that information not be made public. It's easier to obscure it. Mm-hmm. So I think for us, and our challenge at Leapfrog has been and continues to be to simplify this message, to make it very clear to consumers what's at stake, what information they can use, and how they use it to make these really critical decisions about where they go to seek care.
Yeah, and in a way, outcomes like harm to a patient, death is pretty. In a way, you think that would be really easy to count, but it is obscured by, I guess, a whole process or question around how do we know a patient who's already sick died because of a preventable medical error. I guess some of that's just a judgment call. I guess that's why we have different studies with different estimates. What are your thoughts about that, or the different estimates that are out there about harm and death? Which numbers do you think are most credible?
Well, I actually think that the science has come a long way in the past 15 years since Leapfrog started. And although it was the same time as we started, it wasn't only because of us, though I think Leapfrog has had an enormous influence in advocating for better transparency and quality reporting. But it wasn't only us by any means. And there's been some good research to figure out how you measure quality and safety. There's an organization called the National Quality Forum, which endorses measures. There's been some very good research funded a lot by ARC and others that have really looked to understand how you measure that. Because what happens is if you say, well, one hospital has a death rate from heart surgery that is, 12%, and the other one down the street has a rate of 25%. So does that mean that the one that's got the 25% rate is worse than the other one? Well, not necessarily. It could be that the one that's got the 25% rate actually sees sicker patients. They have maybe a physician who is an expert at dealing with extremely high-risk patients, but automatically would have a higher death rate simply because they're much more complex procedures. So you have to be able to standardize for how complex the procedure is. You have to be able to standardize for the kinds of things that come into play when you're comparing among providers. That would skew the results so that you're not getting the information you need as a consumer. So all that to say, that's changed. And we now have some pretty good measures so that we can compare apples to apples. When we say one hospital has this rate for this procedure and the other hospital has this rate for this procedure, you can look at that as a consumer and say, oh, well, this one seems to be better. And that will be true, because there are very, very good measures out there. But it's taken us a long time to get there because no one demanded it before. And for that, I will say Leapfrog's had a big impact. We've put the demand in the market for information so that we can compare among hospitals. And that has made a big difference for all of us, not just consumers, but hospitals themselves. They compete on quality.
Yeah. And you're saying, in terms of some of the measures that you're collecting and reporting, these get very granular and specific. There's also the big picture estimates. The report To Err is Human from 16 years ago, I think they estimated a range of 44,000 to 98,000. There's different estimates of 1 or 200,000 deaths in the United States each year. Is there? I mean, it's a big problem either way. Is there a number that you think patient safety experts can find most reliable?
Well, the number that most of the experts we've been working with have started to use was in the Journal of Patient Safety, and it says anywhere from 200,000 to 440,000 deaths per year. And those numbers are so astronomical that it's hard to believe that could ever be true. But I'll tell you why I think, for example, Lucian Leap, who's really the founder of the movement, has started to think that study may actually be the one that we should be looking at for understanding the rate of mortality, is that over this period of time, I would say the last 2 decades, where we've really advanced the science, we have begun to identify even more ways in which errors and accidents and mishaps, things that we don't want to have happen at a hospital, do in fact happen. And we've actually expanded the range of those, of our understanding of them, and actually identified more of them. So an example would be misdiagnosis. This is a new, entirely new, it's not a new concept, but it's a new idea that we may ultimately be able to measure, or at least get some gauge on how frequently there's a misdiagnosis that results in harm to the patient. The Institute of Medicine just put out a very highly discussed report back in the fall on misdiagnosis and what can be done about it. Also requires a systems approach. It's not about one person making a mistake. It's about a system that doesn't catch a mistake. So in any case, that advancement has actually led us down a road of finding even more problems than we thought existed in the past. So I would say that right now we're still trying to count the bodies, and we're still trying to understand the extent of the problem. We're even still trying to understand what the problem is. Yeah. So I think we're still in an early stage, but we're farther along than we were.
I wanted to go back and ask a bit of a follow-up when you talked about companies asking hospitals to give information to Leapfrog Group. How many hospitals do you find, is there a percentage that are just unwilling to share that sort of data involuntarily, or to share it voluntarily?
Well, we officially ask about 4,000 hospitals to report to us. And we've had a record year this year, more than any year in Leapfrog's history by far. We've had 1,750 hospitals reported in 2015. So we were very pleased. That's a lot of hospitals. And a lot of them are larger hospitals. So we now are covering probably more than half the beds, inpatient beds in the country. Mm-hmm. But we still aren't, that's still a lot of hospitals that are declining to report, despite the request from their local, their local employers. So we're still not where we want to be. I will tell you that there's a lot of reasons hospitals have given us over the years, or have given our employer members over the years for not reporting to us. And those reasons, I think, really come down to not having a culture of transparency. They just aren't used to the idea that they would make public information that's so sensitive to them. And I truly think that hospitals, once they get past that initial fear of making public what they haven't had to make public in the past, once they get past that fear and they start to actually immerse themselves in transparency, it changes. Typically, hospitals that start reporting to us keep going because they get so much value out of it. They had not realized until they took that plunge, how important that would be for them internally. Forget their positioning themselves in the market in a positive way as a transparent provider. That's a great value. But what they've also found as a value is it really galvanizes quality improvement in a way that nothing else does. So, but it takes a plunge. It's a different way of thinking about how you do your business. So I do think for hospitals, pushing them to the edge to take that plunge has been our challenge.
And I'm sure it can sting some of these hospitals. There's the hospital safety score initiative. Maybe you can explain that a little bit for the listeners. But if a hospital thinks, that they think our quality is good, and they get a C or a D on the hospital safety score, do you find? I guess the question is, do organizations find that motivating and a rallying cry, or do they complain about the grade? I guess it's the same as any student might do, right?
Yeah, it's both. Same as it would be for any student, right? Both. We get lots of complaints, certainly, and I understand that. And we also hear the rallying cry. But I will tell you, the hospital safety score, to me, has been very successful, in particular in one area, and that is getting the attention of hospitals to focus on quality improvement or safety improvement in the case of the hospital safety score. I think this has had an enormous impact on hospital leadership, meaning both the boards and the C-suites, in getting their attention paid to their safety record and how they can improve. Now, this is anecdotal. I will not tell you I did some big study on this, but I can tell you that virtually every hospital leader I've spoken with said that getting less than an A got their attention, and preserving their A also gets their attention. I've talked to numerous board members from various hospitals that say their board had been hearing for years how great this hospital is on safety, and then we open up the paper, and on the front page it says we get a C from the Leapfrog group for hospital safety score. We look at that C, and that comes up in the board meeting. They want an answer. And it's not that easy to just say, well, Leapfrog is just this crazy organization. It's not, our science is meticulous. Our expert panel is a dream team of the top national experts on patient safety, and we're totally transparent about how we got to that C. So it is, it's not as easy to dismiss as perhaps other things might be, and that gets the right attention. So I am very excited about the fact that we are seeing this level of effort and true competition now among hospitals to get to that A, to really show that they care about safety, that they're making a difference in safety. And I think more than anything else, that's going to change things. I'm also hearing, by the way, related to that health systems in particular are actually putting the safety score into compensation contracts. We're hearing about it. I ran into the head of HR for one of the largest hospital networks in the country, and she said, oh, you do the hospital safety score. Well, that's a mandatory question for any CEO candidate for any of their hospitals. Mandatory question, what is your hospital safety score? So that's going to change things because, Ashish Shah, my friend from Harvard, he always said something that I think is so important. The day that a hospital CEO gets fired because the hospital's not safe, we'll see the complete change in safety across the country. And so now, I'm not saying I want all the CEOs to be fired. By no means. I don't want that. But I do see that people need to feel like safety really, really matters to them, to their jobs, to their industry.
Yeah, I think it is telling, though. I mean, you raise an interesting point there. Sort of, raised the issue before, how auto industry CEOs get called in front of Congress to testify over product safety issues that lead to 10 or 20 deaths across the country. I don't think the same thing is happening with hospital CEOs. Being not that calling people in front of Congress necessarily helps any more than firing people does, but I think it just kind of speaks to the lack of public attention around the issue, that CEOs aren't being called on the carpet to explain the results or what they're going to do to improve safety.
Right. That's such a good point. I think we haven't looked at patient safety the way we do harm in other industries. I think it's partly because it happens on an individual basis, and a lot of people think it's their family's the only one that ever went through this. Mm-hmm. They don't realize that it's endemic. Everyone I've ever talked to has a story of a safety problem in a hospital. If they've been to a hospital, they've had a problem, at least from my own experience. But they think it's just them. And so I think there's partly that. I think also the people in hospitals, are frankly, they're very sick. That's why they're there. And I think there's some, perhaps in the back of our minds, there's some sense that, you go to a hospital, you might die. That's what happens. So maybe that's all this is just people dying because they're sick. But in fact, that's not the case. And that's why it's so important for us to look at preventable errors and accidents that are harming people. And not everyone in a hospital is that sick that they should die, but unfortunately you can go into a hospital for a minor procedure and not come out. Mm-hmm. So it is extremely important for us to get a handle on this.
Yeah, and I think you kind of bring up that job interview scenario of somebody asked a hospital CEO, what was the score where you were before? It's possible they don't know, which would be telling, or secondly, if the score is low, that would be telling. But in my experience, I wonder if, it seems like a lot of CEOs think they can delegate safety. We've hired a quality person. If there are safety problems, we'll blame and punish the individuals involved. If you look at surveys done every year by the American College for Healthcare Executives, I think the thing that's most telling, curious to hear your reaction to, when they ask hospital CEOs, what are your top concerns? Patient safety almost always it does come in consistently fourth behind issues like finances, health reform. It seems like, the CEOs are focused on the financial piece, which is important, compared to, say, a Paul O'Neill, who you spoke. I was really happy to see you speak at your recent Leapfrog group event. Paul O'Neill took safety very seriously and was very responsible for it as CEO. So I'm curious what your thoughts are on that whole approach or mindset.
Well, patient safety in hospitals, in the healthcare industry, doesn't tie to finance, typically, or at least not explicitly. So, when we look at the data on what happens when a hospital is unsafe, the people who pay for that lack of safety financially are the payers, the purchasers, like my members, and those who are paying the bills. That's who pays for it. So the best example of that was the study in JAMA back in 2013. Etul Gawande was one of the authors, and it talked about how much extra was paid when there was a surgical site infection at this hospital network in the South. And they found that on average, Medicare paid $3,000 extra every time there was a surgical site infection, on average. But commercially insured, meaning my members, purchasers, paid $39,000 extra. So the money that is covering the cost of problems and complications and errors and just all of the issues that are associated with patient safety, the money that pays for that is coming from the payers. It is not necessarily true. It can be, but it is not necessarily true that the hospital is feeling the sting. Now, you take another industry, and it's inconceivable that you would pass off all the costs of your error onto a consumer. And that's why they are very safety conscious, because they don't want to pay those extra costs. Mm-hmm. So, and now Paul O'Neill is extraordinary, and he put an extraordinary amount of attention to safety. So he was amazing when he spoke at that event. But so safety is a concern for every industry. But the financial incentives in healthcare make it very easy to put safety fourth on your list. Mm-hmm. The financial incentives in most other industries make it catastrophic for you to put safety fourth on your list.
Right. So if that's maybe a systemic barrier to safety improvement, the reimbursement and payment system, that's pretty much uniform across the U.S. So what are some of the other factors, though? Why is there, as you mentioned earlier, a large gap between the best safety performers and the lowest safety performers?
Well, we had a little Twitter conversation, you and myself and a couple other people, about leadership in hospitals and how important that is, and to galvanize a culture, which is also very important. I do think leadership is critical. I have had the privilege of touring a good number of hospitals, and honestly, I can always spot an exceptional performer. I can't always tell the difference between average and, above average. That you can't tell from the people, just on a quick tour. But I can tell the exceptional ones often. And one of the factors of an exceptionally high-performing hospital, and I'll give the example of Virginia Mason, which does use Lean and Six Sigma and Toyota model. They've used some very important and cutting-edge strategies for improving their quality, and they work. Because their quality data, and I don't say this lightly, their quality data is exceptionally good. Mm-hmm. But what you notice out of Virginia Mason when you're touring is that they are restless. They are not. They're unsatisfied. Mm. They never say, "Oh, well, look how great we did on this." Period. They say, "Well, we're doing really well. We're really proud of this. We've got all this reporting going on and we've seen a real decline in X, but we got to do better than that. We still have 2 or 3 of these every year, and we got to get down to 0. And here's what we're doing." And they're just never satisfied with their own performance. And I think you, Mark, at our annual meeting last year, talked about the importance of thinking about your quality improvement as an ongoing process. Mm-hmm. You're never, ever satisfied. If you're satisfied, you're not doing Lean right. Mm-hmm. Mm-hmm. And that, I thought, was just such an important point. I think oftentimes hospitals have one campaign, let's bring the central line infections down to 0. That's our campaign for the year. We get there, congratulations, pop the champagne, we're done. That's not how it works. That's not the best way to do quality improvement. You actually have to see it as a journey that never ends, that you're always on and that you're restless and you never satisfy yourself until you do better and better and better. That's what I see in the exceptionally high-performing hospitals. But leadership is critical to that. You have to have a leader who's restless, a leader who's pushing, a leader who's never satisfied with a good answer. They want a better answer. And I think that's what I do see. The twist, I would say, though, it's not just about being that great leader, but being an accountable leader. I think it is so important that boards, that fellow staff, that medical staff, that hold leaders accountable for the results, whether it's in your compensation contract or it's in your public displays or public awards. It's in a variety of ways to hold leaders accountable. If they're not accountable for getting that performance, for pushing for that performance, then it won't happen no matter how good the leader is. Accountability is a critical factor that's often missing in healthcare.
And it's really interesting you had that observation about being restless, never satisfied. I mean, that is something I would recognize as being sort of a core Lean mindset. This this pursuit of perfection, realizing we're not going to be perfect next month or next year, but we're kind of driven to challenge ourselves against absolute goals of 0 harm or 100% compliance on certain protocols or checklists. That is very much a Toyota principle, and I think it seems like that's one that's not easily copied. For an audience, we're talking to an audience here that knows Lean and understands the challenges of it's easy to copy Lean tools, but if you plug those tools into a different environment, you might not get the same results. So it's interesting to see where I wonder if there are organizations out there that already have that sort of mindset, even just regardless or independent of Lean. It seems like that would be fertile soil for bringing in some other Lean practices, that level of leadership and accountability and, if you will, just energy for never being satisfied, not just being top quartile even, right?
I think it's, and I have seen it in organizations that don't necessarily have a lean strategy, but they are, somehow you see it. You see the spark of that. And, it sounds almost depressing to call it restlessness, I guess, but it isn't. I think part of the problem with burnout that we're seeing among physicians and nurses comes in part from being satisfied with mediocrity, or from cultures that say, well, we're doing okay, we're fine, and we know we're not fine. But we all say we're fine because we don't want to have to rock the boat, and we got enough to deal with without having to deal with that, blah, blah, blah. But that is, if that's your life work, is caring for patients and restoring their health and making a difference in their lives, if that's your life work and your passion, you should never be satisfied. You should always want to do better and better. That's what's going to galvanize us. That's what gets us up in the morning, is having that incredible life purpose that comes with a career in healthcare. So I actually think that that feeling of wanting to never ever be satisfied without anything short of perfection is what's needed to really inject excitement and enthusiasm back into healthcare settings where there's this feeling of burnout.
And so maybe as we start to wrap up here, sort of talk about the different stakeholders in the health system and awareness about these problems, because we're still far from perfection in healthcare. I think even the best organizations would acknowledge that. So you've talked about the hospitals and their leaders being aware of the problems, the payers becoming more aware of the problems. What can we do, or what still needs to be done on the patient side? Because I still think there's a lot of just sort of blind faith or trust in the healthcare system. I think people are still very willing to just go where their doctor recommends, or to go to the hospital that's closest, or to choose the hospital that seems to have the nicest, physical design. What do we still need to do to help people realize that, A, there is still a problem here, and B, that they should go out and do research and try to find information from groups like Leapfrog Group? How do we reach more people about that?
I actually think that the new emphasis on price transparency that we talked about earlier, this new, it's really a movement to try and help consumers know how much, or anticipate how much a particular procedure or office visit is going to cost them. That new emphasis is opening the door for consumers to think differently about how they select a provider, and to think differently about their role in the healthcare system. Because as you said, I think traditionally patients think of their role as to do whatever their doctor tells them to do. And so when suddenly you pay more of it out of your pocket, which unfortunately or fortunately, however you think of the world, consumers are paying a lot more out of their pocket now. And you are suddenly concerned about how much that's going to be. Your second question, after you ask the first question, which is how much is that going to cost me, that procedure? Your second question is always, well, why is it costing one thing at one place and another thing at another? What's the difference? What's the difference? And the difference is a quality question. Is it better quality at the hospital that's lower cost, or not? And when people start asking that question and recognizing that they do have a role and a big stake in picking among them, then I think that will change. It's a cultural shift that we have to see happening. But I'm seeing the tipping point coming because of this, because again, I think people have entered this questioning through the door of pricing. And I think that's where it's going to start.
Yeah, and I think there's also the counterintuitive idea of the relationship between cost and quality in healthcare. I'm sure a lot of people might say, well, I'm willing to pay more for better quality, when I've seen a lot of data that suggests that, well, actually, if all you had was cost data, that lower cost tends to be in line with better quality, which I think for somebody in the lean methodology would realize that that's possible and that makes sense. But I think that is really counterintuitive to a lot of people about where they think quality comes from. It doesn't come from spending more. It comes from having better systems, better processes, reducing waste. And that has, I think, the happy double benefits of improving quality and cost at the same time. How do you see that?
Absolutely, that's absolutely the case. However, I would add one additional twist to what you're saying, which is the fact that in healthcare, at least from what we can see, price, which is different, by the way, from cost. Cost is what it costs the institution to provide. Price is what they're charging you. And charge, I hate that word, because we always think of Medicare charges, and it's not charge either. It's what price is, what Mark Graben is expected to pay for that visit. That's the price. And so prices and quality and safety data rarely match. So they're sort of all over the board. There can be some very low-priced providers that are providing excellent quality, and some are providing poor quality. Mm-hmm. You see that in all over. There's really, because pricing has not been associated with quality in the past. Never had to be. So that's changing. And that will change when more people start asking all those questions and wondering. I think that's what happens in a market. Mm-hmm. And it changes things very rapidly.
Yeah, and thank you for bringing up that point. Yeah, you're right. Cost and price are different things, and it seems like a lot of healthcare pricing is based on the relative size of the organization. It's at least among private payers. Our health system is relatively large, so we can put pressure on the insurer to pay less, or vice versa. We're a huge insurer. We can bring lots of patients to you. Therefore, we have the size and leverage to force prices down. That dance, it seems, has very little to do with the data around quality and safety, right?
Right, and the pricing has been entirely driven by those considerations. What's our position in the market? What can we get away with? And the market being for payers, not for individual consumers. And in addition, it's been driven by what government tends to do, which is to base it off costs, what you say are your costs, what we agree are your costs, however we do that. And, when you look in literature about pricing for other industries, in, B school textbooks on pricing, the word cost barely comes up. It's really not a factor of costs, or maybe marginal costs a little bit. You have to consider it, but that's not what pricing strategy is about at all. And that is usually perplexing to people in healthcare, because they can't understand that, because so much of it is driven by costs, or at least ostensibly by costs in healthcare, and it's a completely different world. When we take the veil of down and we look at healthcare, and with the cold eye of a free market, it changes everything.
Yeah, and that's a great point. I think the lean thinkers in the audience will recognize even the Toyota books from decades ago point out the idea that prices are set by the market, and if you can reduce cost, you increase profitability. If your costs go up, you're not entitled to go ask your customer for more, because the customer will find alternatives. The market will punish you. And I think healthcare is one of those industries that's still trying to get over the old mindset of, well, our costs are higher, we'll just charge more. That's not going to fly.
Exactly. That is exactly right. And the word that best embodies that mindset is the word reimbursement. Mm-hmm. Yep. You don't go to Walmart and buy, I don't go to Walmart, buy a toaster and reimburse them for the cost of them having provided me a toaster. I don't reimburse Walmart. I might decide not to buy it there. I might go somewhere else. They're not entitled to a reimbursement. They've just lost it because they didn't give me the right choice. So the reimbursement is a word that embodies that culture, and the change that's happening now is it's payment.
Yeah.
And payment's different.
I've never heard anyone point that out, but now that's really insightful of the meaning. The words tell you a lot about the thinking. So, well, as we wrap up here, I do want to encourage people who are listening to check out Leapfrog Group's website. You can also go to hospitalsafetyscore.org. I'm scrolling through the hospitals closest to me. I see A, C, C, A, B, A. Well, there's a lot of A's, but then I see, jumps out at me. The Public Safety Net Hospital in Fort Worth has a score of a D, while its counterpart on the Dallas side of town has an A. So that, even just in a microcosm, probably exposes the difference. Those are two hospitals very similar in size and scope and mission and there's a big variation as played out in those scores.
I think that we focus entirely on safety. So in other words, the bad things you don't want to have happen when you go to a hospital. Our score, that letter grade, A, B, C, D, or F, is not focused on how well the hospital does at the procedures you go to them for. Mm-hmm. So it's not considering the quality element. How do they do? How well do they do in certain surgeries or something? We're just asking the question, what's their complication rate? What's your likelihood of getting an infection, of having a error made on your medications that harms you? Those kinds of things that you don't want to have happen. That's what the letter grade's about. How safe are you in that hospital? And that is different, but it's critical. It should come first. Mm-hmm. You safety first, yep. Right? You don't want to go to a hospital that's not going to take care of you before and after the procedure when you are at a vulnerable state. So right. These are very important. And it's also why it doesn't track with what you think. So the big brands in healthcare, the big names in healthcare, they don't all get A's by any means. Mm-hmm. And that's because they're not always focused on safety the way they should be. And hopefully, by at least raising the question of why didn't you get an A, when a few patients do that to some of the physicians and others at the hospital, that will change things.
Well, I want to thank you, Leah, for raising those questions and for all of your work and advocacy and everything you're doing to help improve patient safety. Again, my guest has been Leah Binder from Leapfrog Group. Thank you so much for being a guest today.
Well, thank you, Mark, and thanks for all your good work getting us there as well. I think you've really made a difference yourself.
Oh, well, thank you. I appreciate that.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.